Those were really terrific papers, and I really, really enjoyed the session. I just wanted to kind of seed a few thoughts. I think the title for the discussion was opportunities and challenges, and just a few things that I think, especially given that this audience is so interdisciplinary, my sense is one thing that some of this research also shows is the value from collaborations between people working on mental health, between psychiatrists, psychologists, economists, other social scientists, because particularly I think one thing that I think we could do a better job of in this literature is measurement. So when economists study mental health, it's sort of often tacked on as some outcome that they maybe don't pay a lot of attention to, and then later find an interesting result and it becomes a big part of the paper maybe, but we don't really know what we're doing. And I guess one is allowed to say this more about one's own profession, but when I look deep into the weeds of how psychiatrists who've done clinical trials, also measured some economic outcome, which is an important part then of their paper, or at least a secondary part of their paper, you'd look at it, and as an economist, you'd have shivers. So it's not the good kind of shivers, the bad kind. So if we can work together, I think there are enormous opportunities to do better on measurement. So when economists are doing a bunch of big surveys and collecting data, if we can collaborate with people from working on mental health, we can add those measures relatively easily, and we can learn so much in terms of the effort put into validation of measurement, which economists often don't bother to do. And similarly, perhaps people doing clinical trials and so on mental health could do more to measure econ outcomes. And one thing, if anyone here is interested, there's so many of these clinical trials are done in rich countries which have amazing administrative data. And if we could go back, the way we put years of effort into tracking down these people in rural India, and then did our survey measures. But imagine if you could follow up on trials done in Denmark, or Sweden, or Germany, or countries which have amazing administrative data. Go back and look at these economic outcomes. It feels like there's enormous potential there. The other thing that this last talk, which I thought was just fascinating, made me think about how we should think about welfare and revealed preferences here. So economists often put a lot of weight, and behavioral economists like me put a little less weight, but still a lot of weight on what would people choose, right? So in the study we just saw, almost surely if we asked people, would you like, once again, to get a $500 stimulus check, or a payment, unconditional payment, or $2,000? We're pretty sure they would say yes, right? But it is, seemingly harming them in some ways. At least if we, to take those results and they're carefully measured and so on. So how should we think about putting together these different aspects of welfare, and kind of what role is there in thinking about revealed preference when we're thinking about mental health, right? And there's a connection between Dan Bennett's paper and the last paper. So Dan was showing us that people's willingness to pay, their revealed preference for something that might be good for them, is itself affected by mental health. And anyway, it just makes my head spin, but it seems very interesting. And finally, I think I wanted to say, we're just scratching the surface of this work, especially in economics and as social scientists. And there's a lot more to study than, depression is a very important, very common health condition, but there's anxiety, there's PTSD, which is incredibly common in many parts of the developing world, in post-conflict societies, but even outside them. Psychiatrists, mental health professionals have done a lot of work on that. I think there's a lot for us to understand there. And finally, to wonder, is there a scope for these kinds of interventions, not just among populations who have clinical levels of mental ill health, but for the many, many people who have subclinical, levels of psychological distress? And that's something I think we don't know much. I don't know if that's what I was supposed to do, but I wanted to kind of throw out some questions to see if there are kind of reactions or thoughts, and that's what I have. Did I do a good job? All right, thank you.
I can kick it off with a question. So I have a question for the panelists and maybe the group more generally. So I think one of the things with the most recent paper that was presented, and just some of and also in Dan's work, is this idea that you're doing this mental health intervention, which people in self-reported depression goes down, and clearly in some ways you would think is making people better off just because they're saying they're less depressed. But then people who are less depressed, some of them are going to go work more, and some of them are going to go invest in their kids' educations. You might imagine some of them are going to take very different kinds of behaviors, and that'll be different for different people. And each of those might be positive behaviors, but then when we do a survey with 30 outcomes and then adjust for multiple testing, it's very difficult to detect those. And this was really similarly a problem with the microfinance studies. Like, you give people microfinance and it was hard to find effects because they were just so dispersed. So for you guys doing this work, I'd just be curious to think about how you think one can make progress on understanding if there are benefits, what the benefits are, given that the benefits will be so dispersed across different outcomes for any given person.
I have one thought on that which is I discovered something psychiatrists have sometimes done while studying particular kinds of therapy, which I thought is amazing, and I think we should. I'm very excited to try it myself, which is basically letting participants define themselves what their goals are, like what would they like to achieve. So these are in the kind of therapy where typically you're working on improving people's relationships, so not things for depression and so on, but saying, well, what would you like to get out of this, course of therapy? And then going back and checking, did people actually, improve on those things? Now, of course, it's a difficult thing if Dan is telling us that preferences themselves are going to change as a result of therapy, then it's hard to know, should we respect the old preferences or the new ones? But it struck me as kind of a remarkable thing, because exactly we do these studies, we measure many things, partly because we have a very diffuse prior about where the effects will be because there isn't enough work done yet. Also, by the way, makes it so hard to write papers because then you have all these endless results and referees get bored and so on. But also we could in a way democratize kind of what we're doing. Economists were so like knee-jerk, thoughtless, just measure consumption as the outcome. Like that's not necessarily what people care about. Why don't we give power to the participants of our studies to define what they care about and then use that as a pre-registered kind of outcome measure? Like how much progress did they make towards that? Anyway, it's something I think would be very cool to see in econ studies.
Maybe just to add to that, because I completely agree, and I've done a lot of work looking at, epidemiological surveys where people, you can identify people that screen positively on having more even severe mental health problems, and then they don't seek help, and then we follow them up with interviews. And okay, so why didn't you want to get any help for your mental health problems? And a lot of them, they'll say things like, well, I don't know, I'm poor, I'm not depressed, or I'm just actually, of course, they won't be surprised that you tell them, oh, like you have this higher score on some depression outcome, but their kind of framing of it is much more around like a reaction to life, and the framing and what their solution, preferred solution would be really different also. So no, I think that's really important. You have to then think like how you. I guess, right, how you do individualize the programs more, but I think giving more opportunities and more pathways and modules for addressing different issues. And I think also your point about right, also in terms of how interventions are organized in terms of those universal and selective and more indicated programs. And I think you were talking earlier about, right, all the like people with sub-threshold symptoms also, but then how do you also target programs for people with these different levels of mental health problems? Yeah.
I guess questions to anyone that sort of may have thought about it, but I wonder, like from the perspective of a policymaker, how do you trade off those things? If you see that people's objective outcomes are improving, but the subjective outcomes are not, how do you trade off those things, and what should we pay attention to, and how much weight you put to those things?
Hi. I think one thing that came to my mind is the subject of data mining and sharing knowledge and the studies, because it seems that there's information that can be further mined for results and to, reveal conclusions. And I think that would be a very, very good start.
Do we have any from the Zoom chat? Well, then I would come in with a more broad question about where this field is going and what the aim is of all this research. So, throughout these sessions, I always thought it's amazing work. I really liked all the talks, but where does that get us? So, people in poverty experiencing depression more often than people who don't live in poverty. But then we also know that poverty perpetuates itself, and poverty is really also a more relative kind of concept, right? And so I guess something that I feel that I would strive towards more is fighting inequality as a broad concept, right? And so maybe one outcome measure that I would love to see more in these debates things like political participation, because as long as we individualize the problem of mental health in scarcity, we can only fight that individual person. And I think there's a huge merit to that, right? I don't want to just drop all these people who live under scarcity right now, but in the long run, we can't just keep treating millions of people living in poverty with mental health programs, right? The ideal world I would want to live in is a world where we just don't have to treat people with mental health problems. And so maybe this is just a comment, but maybe also a question of whether people have thought about kind of also measuring political participation or kind of self-efficacy measures of how we can strive towards a better society in bigger terms. Not sure whether that made sense.
Today that's going to
oh, great.
part of it.
Cool.
So I'll say just one thing about that, which is not answering you in terms of studying political participation and so on, but there's this intriguing fact, and we mentioned this in this review paper we have in Science, which is that if you look within a country, or many studies looking within countries, we tend to find this negative association that is, people with lower incomes and other markers of low socioeconomic status tend to have worse mental health. Intriguingly for the economists in the room, that relationship with consumption seems to be much more flat. So it's more a relationship with employment and income and not consumption, which tells us something about models of consumption smoothing and so on. But when you look across countries, you really do not see a pattern like that. So it is difficult putting together, the global burden of disease study. They try their best to put together these numbers from different countries. But if you plot GDP per capita against the prevalence of depression and anxiety, it goes in exactly the opposite direction. That is, richer countries have higher rates of depression and anxiety. Now, some of this is surely to do with underdiagnosis, even though they try to do this using epidemiological surveys and so on. But at least it seems like pure economic growth may not, or just everyone in the country being richer may not by itself reduce the burden of disease from mental ill health, which is very different, which is one way in which mental health seems very different than certain aspects of physical health, right? If you did that plot for most kinds of physical health, you'd find in richer countries people are healthier, but we do not find that for mental health. And I think that's interesting, important, and potentially related to the mechanisms you had in mind.
Right. I just wanted to contribute something that was inspired by my grandmother. So she grew up very poor, and her favorite phrase was, "What will people think?" She was obsessed about that, and it was really about respect, about having self-respect for herself and being respected by others. And one thing that I realized through her eyes is that it's very, very, very easy for a poor person to lose their self-respect and to lose the respect of others. There's so many things that they can lose respect for. They didn't show up dressed properly. They took shortcuts that were not they were illegal or immoral and so on. So the other thing is that a lot of what respect was about for her was about something we would call morality. So basically, are you doing the right thing in terms of so I think this is a dimension that I haven't seen. It's close to something that we call self-image or social image. It's close to ego relevance. So we have concepts that are close to it, but they don't integrate this aspect of social norms and the eyes of the others on you. And also, in fact, she was worried about the eyes of others on her even when nobody was looking. So she was completely happening inside her head. And so some of the things that we discussed today could have an explanation about, these treatments not necessarily generating self-respect or social respect.
Hi, this is, I didn't introduce myself earlier. I'm Catherine Thomas from social psychology at Stanford. And on that point, one question was, has anyone done research with frontline workers and trying to increase the dignity with which they treat the patients? Frontline workers or community health workers, and seeing how that affects treatment outcomes. And then my other question was on thinking about different types of psychotherapy. So we're talking about kind of CBT and psychotherapies are kind of a black box. They do lots of things. That's kind of the goal, is that they kind of address a lot of issues all at once. And I'm wondering if there's some interest in moving towards looking at different types of therapies to kind of more accurately understand the mechanisms. So for instance, there's been research on meditation and neuroscience. Different types of meditation affect different brain regions over time. So if you do compassion meditation, you see more empathy light up in the brain, or perspective taking affects metacognitive abilities. So I'm just thinking how we might kind of test out interpersonal therapy versus cognitive behavioral therapy focused on behavioral activation, or cognitive restructuring, and kind of maybe more discretize the modules of different types of therapies to look at their effects on economic outcomes.
Okay, great. We'll let people marinate on that one, and we'll break for lunch, and we'll take lunch until 1:30. So we'll see you back here at 1:30. And feel free to keep having conversations, because that's what this is for. Thanks.